Welcome to Fireside Chats, Leadership Journeys, brought to you by the Office of Academic Clinical Affairs and hosted by Dr. Carolyn Porta. These chats bring together University of Minnesota Health Sciences students with experts for candid conversation on leadership, career pathways, sources of joy, and strategies to rejuvenate.
Welcome and thank you for being a part of this fireside chat for the 2024-2025 academic year. We have with us Vice President and Dean Jakub Tolar, and it's a pleasure to be able to moderate our time together and to hear more about him. I learn something new every time, and it's a pleasure to have these conversations. It's a gift. It's a gift of our time and of his time. And I invite you all to put questions in the chat as they originate. But certainly I'll get us kicked off and just say, welcome, Vice President Tolar. Who is Vice President Tolar? Let's start there.
Well, first of all, this is your time, not my time. I'm not here to tell you things, how you should lead your life. I am more serving you in a capacity of somebody who has been in your shoes, and I have a profound admiration for the program, for what ABP Porta has put together, this fireside chat. So you direct me whichever way you want.
All right. So again, please put your questions in the chat box as you have them, and I'll get us going. So Dean Tolar, when did you know you would be a physician, and what was that journey, that discovery like for you?
Good question. And it's impossible for me to tell you the exact point. I can give you the context in which it happened. And first thing is that I have not planned to be in the United States. I have not planned to be a dean. I have not planned for almost anything in this. It really has been, I have been defined by people I have met. I have been given gifts, unearned and generous, that somebody opened the door for me or showed me some opportunity where I can be useful. And the decision to become a physician came as a part of that journey. I can tell you that it is not a specialty dependent at all, but I always, from very early on, was struggling with relevance or irrelevance, whichever way you look at this. I am asking myself frequently, as I had 45 years ago, am I any good? Am I useful to someone? What is it that I am here to do? And it is true that I have always been curious. I have always been able to accept risks that perhaps others won't, which is, again, innate. There's nothing to do with me personally. And I've been very comfortable with people that are quite different from me in any way you look at this. So to give you because I know that ABB Porta will drive me to this eventually. I grew up in Prague under the communist regime, and I went to medical school when I was 17. That's how the European thing is organized. It's a 6-year program, not 4. So you end up as an intern. I started as a trauma surgeon and loved it. Adrenaline job, it clearly, was an athletic thing in many ways. And and I was simultaneously interested in science. And when I was able to do that, which is after the fall of communism in 89, in beginning of the 91, I think, I went to Cambridge in England and was able to work with people in molecular biology realm, which I liked very much. And then I was told by the National Health Service that I can either keep my practice at Edinburgh Hospital or my lab in at the Department of Pathology, where I did my molecular stuff. And I didn't want to do that. So people who knew how I think, and again, it's another of these open doors and gifts. They said, if you want to ever be any good in this molecular biology, that you like get a PhD from the States. And this place was the third PhD program in the world in molecular biology at that time. And we had my wife and I had a 4-year-old daughter at the time, and we didn't want to live on the coast. So we came here, and I loved every moment of it. Everyone. I did my PhD in about 4 years. Then I asked myself again, coming back to the being useful, how can I blend the interest that I had in high intensity medicine and molecular biology? And I thought pediatric cancer is going to be the right answer. So I got quick, you cannot do it anymore, but quick pediatric residency, and then went to fellowship in hematology oncology and in bone marrow transplant. And my work has been for, since the beginning of this century, has been in developing clinical trials for difficult to treat or untreatable at that time rare diseases and cancers. Is that okay?
That's great. And I see that I will get to your question, Blair, about deanship, but prior to that, I am curious if there's a memorable case that you've handled as a trauma surgeon or as that pediatric oncology surgeon, thinking through years of clinical service. Is there a case or two that jump out for you and left an imprint?
Well, yes, thank you for the question, because that gives me a permission to tell you that I have learned from my patients how to live my life. Simple as that. I've chosen this because it's difficult, and it's not like, I'm not bragging or anything, but I truly get the answer to the usefulness question from doing hard things. And the memorable, there are many of them. I remember my patients probably forever. But I had early on, when I was attending, like one of the first years, I had a girl. I specialize in what's called bone marrow failure syndromes. So that's where you stop making blood. And I designed a new trials for Fanconi anemia and dyskeratosis congenita and severe aplastic anemia. And I had a patient from Western Minnesota, and she had severe aplastic anemia, and she had one of the absolute contraindications to bone marrow transplant, which is aspergillus. It's a fungus that, if you nobody can survive this essentially, and I was able to argue that because the aspergillus was not in her lung, but it was in her clavicle, that it actually can be done. I remember vividly how I worked with her mother and her family. And, these are some of the things that you don't forget, right? Because she asked me, and that's, in the unwritten handbook of oncologists, it says, especially pediatric oncologists, if they ask you, what would you do? Because they do. What would you do if it were your daughter? And again, I have daughters. You are supposed to evade that. You are not supposed to, you are supposed to say something statistical. And I never do. I never did. I honestly answered, to her. And then she asked, what's the chances that she's going to survive this? And I said less than 5%, which is an honest answer. And she was good with that. But then I had to persuade my surgeon, pediatric surgeon, who is a hero of mine till this day, because he was the only one who would touch that clavicle, because I wanted that out so that I can start the chemo. And he faced same fierce opposition in his pediatric surgical group as I did in my transplant group, because everybody said that it's crazy to do that. And we went ahead with that. She developed just about every single complication that you can after BMT. She had she developed she was in ICU for a year. She developed a lymphoma. We call it post-transplant lymphoma disorder, PTLD, in her brain. And I was the first physician who actually treated with an antibody called rituximab intrathecally. I had to call FDA to get a one-person approval for that. And she had neuropathy so agonizing that I put her for 3 weeks in a coma because I couldn't control her pain. And then she lost her sight. She went blind because of the lymphoma in her brain. And her mother, and she survived. And her mother calls me and she says, Ashley has I can say her name because it's been public and I'm not breaking anything. Ashley, tells me that she can see and she wants to talk to you. Okay. So the other thing that I do that we are told never to do, every single patient I've ever had my phone number or a pager number or both. And I always answer it. I always get back to my patients first. And Ashley comes on the phone and she said, I am sitting in front of a TV and I am looking through the hole in the Cheez-It, that little square cracker, whatever, and I can see. And I realized that what she has is, it's known to the ophthalmologist. I've taken care of a lot of retinoblastoma kids as well. So it's known, that if you limit the peripheral vision, you can actually increase the acuity in the center of the vision. And so then we had her tested. She regained her sight. And then, as Holden knows, because she drives me there, I have opened, we have several of the locations around the state of Minnesota. And one of them is in St. Cloud. We have a family medicine residency, and now we have opened new medical campus there, and we do a lot of things. We work with them very closely. And I walk to the room of the coordinator for the residents, and there she is, Ashley Davis, sitting there, working, that's it. So that's my story.
It's a powerful story, and it has triggered a few questions and follow-up that I think will be great. When you mentioned that you've learned from your patients how to live, the question then is, how are you living? Can you share some of those lessons?
Well, first is an obvious one, but it takes time to internalize this, which is we all are one lab test from a very bad day. And I don't know if humility is the right, but it's kind of humility. You still are confident, because you are better be confident if you are given the privilege of being part of life of people at their absolutely lowest. Because when your kid has cancer, that day is the worst day of your life. That's worse than if you had that or your spouse, believe me. So it's a confidence without arrogance. That's one. The second is you pay attention. And I have many role models and teachers, and my disadvantage is that most of them are dead for 2,000 years or 200 years or 20 years. The books behind me are, many of them are there. Francois Bishop, was a physician in Paris. He was one of the first surgeons that realized that our internal organs are separated into compartment by fascias, and you have to think in the units rather than, like this is liver, this is kidney. You have to think about the functional units of the abdomen. And he showed me what I call suspension of judgment. And I didn't know that I am doing this, but when I see, so the huge disadvantage of my practice, if you can call it, is that when people see me, they have seen a lot of physicians before me. And, one of the patient support organizations that I work with have calculated, and they, on average, it's 4.6 physicians they see before me. It's, if you can imagine, it's an enormous frustration for these parents that are going from one shop to another. And they always get, you are the first-time mother, you worry too much, it's gonna get better, and she knows it won't. She somehow knows, or he, this is a father. So my advantage, and the other thing that I learned from my patients is to suspend the judgment. I first did it innately. What I mean by that is I'm supposed to know the textbooks, and I do. But I'm not there for my textbooks. I'm there to open my mind, suspend the judgment, forget for a moment, figuratively, what I know from the chart, because that may be wrong. That path is probably wrong because they didn't figure it out. And I deploy very actively now all my senses. Where's the mother sitting? What is the color of the kid? What is, I'm one of the old school people that think physical diagnosis is really important. I am with Abraham Verghese. I don't know if you know the writer. Another person I learned a lot from. That my residents know that they can never come to me and say, we got this pneumonia on the X-ray or whatever, or tumor on the MRI, without seeing the patient. I cannot accept that a physician or a dentist or a pharmacist or whatever, that you don't go there and do that assessment yourself. So, all the senses deployed, in this. I learned this from my patients. And then I learned that you just don't give up. That's not to say that I have not been sitting down with patients that were dying. I am very much aware of the fact that you can, or anybody can die well or poorly. And some of my best work actually has been done in that setting. That when, and I still remember that, this was on the different continent, that the physicians and the team would say, I'm not even going to go to the room because there's nothing to do. Well, that's true. But I always knew that it's my job to go there, say nothing, sometimes, sometimes say something that is meaningful, at the moment. But being there, being present was the third lesson. Is that good enough answer?
That's great. Great, Dean Tolar. I heard a lot of characteristics, and I'm going to pivot us for a brief moment. And I'm watching faces. People are mesmerized, and it's a sobering conversation. It's a good conversation. You spoke about confidence without arrogance. You spoke about paying attention, about suspending judgment, using your senses, and having that sense of not giving up. And what I have come to respect in my work with you is that you apply these in your leadership roles as well. in addition to your clinical roles. And one of the questions from Blair was, what led you to become a dean? This position sounds, it's very impactful and very purposeful. And I'll leave it to you to answer as you would like about being a dean and being a vice president. I see you living out these characteristics in those leadership roles as well. It's not separate.
It's not. Thank you for noticing that, because my personal and professional life, as it must be obvious, is essentially identical. Yes, I do get back to my family every night for dinner, and I spend my weekends with, as Holden knows, babysitting my granddaughters. And my family is my rock, no question about this. But yes, I always felt that it's artificial when people said, how many hours you spend on this, and how many hours on this, and how many. I don't think that way. I really think that this is that I give it my best when I deploy all the things that I can do in service of what I do at the moment. What I can tell you that is that in the leadership, I'm just going to repeat what AVP Porta said, that I deploy the same things. I pay full attention. Like now, I'm not distracted by anything or anybody but you. I focus on that one thing. I personally think that the multitasking is bogus. I know one person in my whole life who could multitask. Everybody else, myself included, is doing multiple things poorly rather than doing one thing genuinely and intensely. So that worked for me in the leadership. To your question, how I got to this is this sense of this obligation. It comes back again, to that usefulness. So, it started. I'll be brief, but essentially, somebody came to my office when I had full hands with the clinical trials with my lab. I still have our one funded lab. Even now, and I didn't seek any position of that kind, but then they asked me to lead the Stem Cell Institute first, and then we did well with that, and then my predecessor was looking for the executive vice dean, which is the second position in medical school, and again, somebody came, different person, to my room, to my office in Cancer Center, and said, you better put your name in this. And I did, only because of the loyalty that I feel for this institution and for academia and people who occupy it in general. And then they asked me to do it. And then my predecessor, literally broke. This job, and I love my job, but it's, the usual, half-life of a medical school dean is 2.5 years in the United States. And it was just overwhelming. So I got a call from the president then, and he said, that he wants me to do this. So I did. And that's it. That's the story. And what must be obvious, but I'll say this, and I don't mean it in any trivializing way. I am expendable. I don't take myself very seriously. I'm certainly not impressed with myself. I try to do better every day. I take the office very seriously. I take my role as a clinician very seriously, as a scientist very seriously, and as a dean very seriously. But that's not the same thing. It's not about my ego. It's really about the work that I am privileged to offer.
Thank you. What has come most naturally for you in these leadership roles, and what have you had to work on and develop the most?
So what came naturally first is I don't think that I get anxious. I don't think that I'm afraid. I'm very afraid of the health of my children and grandchildren. That's different. But in general, mail of things, I am actually not. And I am comfortable with risks in all walks of life. I know that, and that's sort of unearned, because that, I did not say, okay, let me build some adaptive resilience, so that I am not anxious. No, that's not like that. So these are the things that, that were given to me in this way. What I struggle with is almost every day, several times a day, I sort of check myself and say, could I have done this better or differently? And I take my mistakes seriously. And I started this as a young, resident and whatever. And I started a book for myself, handbook, handwritten, like a journal kind of thing. And I wrote them down, still do. And I go back to this and make myself not avoid them, because some of them are truly painful. I made mistakes, none of them fatal, but I made mistakes as a clinician. I've made choices that I would not make today. And I also, and none of it is about integrity. I actually, that one thing I have never deviated and never will from, but mistakes nevertheless. I, to this day, I catch myself, and as much as I try, some of the things that I do or say or not do and not say are or can be hurtful to others. And that bothers me a lot. And so I try to be, and I struggle with this. I try to go back and make amends if that's what it is, or not repeat it again, or just learn from it.
Thank you. I think that the listeners can see that you are fearless and that you take risks. That's very evident in your clinical practice choices and in your willingness to walk through these doors of leadership. In the fictional world, in a particular line of books, this characteristic would be referred to as dauntless. And I would say certainly you would have been in the dauntless tribe of that fictional book. So I'll just leave that there because I'm positive you haven't read it. But
No.
For those who have, they know what I'm thinking of. Are there other questions coming up for the interns? I have 2 remaining. And again, I'll pivot us a little bit to well-being and to taking care of yourself. The reflective piece you just shared is evidence of taking care of yourself and giving attention to growth. Given the difficult situations you work through, the outcomes related to pediatric oncology, there's a question here about your outlook on life, remaining positive, and whether or not your mental health has taken a hit. I'm sure it has, but certainly how have you mitigated that?
So I'll start with saying the obvious, which is I have chosen this kind of clinical practice as I hope, the practice chose me in a way, sort of abstract way. We sort of self-select, So I have never been regretful of that choice. I certainly take very seriously the challenges and the tragedies sometimes. And I think that my path to well-being in this is really built on the sense of purpose. There's no better, it's a little cliched sentence, I know. But that's what it is. It's I'm as anyone, if I'm, post call and, have, you know, things that are bad happening, I feel it as anybody else. It doesn't really change the course of where I think, that I should be going. On a more practical way, and Holden knows it's true, and that is actually earned and built. I'm very disciplined. I'm disciplined about what I do and how I do it. And I try to give my best for whatever I'm doing, and making that lead me rather than having things sort of surround around me for whatever purpose that is. And lastly, I gain a tremendous support from arts and humanities, and I think that I learned about what I do more from Edward Hopper and Maria Callas than from slide deck on well-being, if it makes sense.
It does, and I'm not going to let you preempt to that question quite yet. And I'm going to challenge the notion that sense of purpose is cliche. It's not.
Oh, thank you.
The literature does tell us, and probably our lived experience tells us, when we have purpose, we are less likely to feel burned out, to feel the effects of the hard work that we do. Purpose is intricately linked. And I agree 100% with the self-selecting into the specialties and the fields. And all of you as interns, we get the pleasure to know you and to work with you as an intern. You are self-selecting into fields based on interests, based on your phenotype, based on your own lived experiences. And when you find that spot, you are really putting together, you're marrying, if you will, purpose with what you're doing in the day-to-day. You are less likely to experience the negative effects of that hard work, whether we call it burnout or moral injury or distress. And at some point, I'll share some of my own journey in my work as a forensic nurse with survivors of sexual violence. But very similar to, I think, the journey of any sort of difficult perceived clinical practice, it's not difficult if you feel it's your spot, if you're there on purpose. And then the second thing I would say as a mitigator of burnout relates to the arts and to well-being, and that is neuroplasticity. If your brain is learning something new, you are less likely to feel the effects of the hard work in the way of burnout or whatever you want to call it. So, Vice President Tolar, where are you finding neuroplasticity moments these days? What's new or planful in keeping that brain fresh?
Well, you said it much more eloquently than I did, but the arts and humanities, I always felt, is a huge part of my work as a physician and as a scientist. And as a leader, because it is almost as if you were depriving as if I were depriving myself of the sources of knowledge if I limited my education to scientific pursuits. And, I am the one who would say that all medicine is based on science. Of course it is. That's not the point that I'm making. I am trying to educate myself, both hemispheres, both the sort of artsy and the scientific one, simultaneously, because it works in the clinical, it works in the scientific, and it certainly works in the leadership work as well. The other part that I didn't mention, but it's a big part of the balance is that I think exercise is a huge part of what I do. So I do, and I'm not bragging. I'm just trying to put this into perspective. And again, hear me out. I don't say this so that you do it too. Everybody is different. It just works for me. So I do an hour of CrossFit every day, every morning. I do thousands of push-ups here in the office. Holden knows it's scary sometimes when people come here and see me on the floor. And I don't eat during the day. I eat one meal a day at dinner with my family, and it works for me. And that's it. So part of my balance is this constant attention to what I am doing. I don't know if it makes sense or not. And it's the same when I listen to the opera. It's the same when I'm playing with my granddaughters. It's the same when I'm in the OR. It's just somehow seems to be very similar.
Thank you. I appreciate that. Would you share a few of your favorite operas and any books that you would say to these interns, if you have free time when this semester is over, here's what I suggest you dive into?
Well, let's start with the operas. I am a big Mozart and Verdi fan. There's I mentioned that I'm Czech. There's one composer, his name is Janáček, who showed me, so Mozart is brilliant, as everybody, I think. And he's like on that Bach, Beethoven, kind of spectrum. Verdi is a storyteller. That's truly powerful for me, the story. And especially if you have somebody who can sing and act, that's a true gift. Janáček is very different, and he, to me, opened doors to parts of my mind that I didn't know I had, that are exquisitely fragile. And I didn't know that I had that. And that was simultaneously uncomfortable and revealing. It's so raw in a way that my wife, who created who I am, by the way, and is absolutely rock of my life, she couldn't listen to it because it's so raw. And I don't know whether this is a sensibility of a Central European or if this is I don't actually know why. And it's not that important that, so these would be the three operas that I would suggest. For books, there are too many, that's the thing. But I always liked people who are discoverers of their own, like Virginia Woolf. I'm a big fan of Anna Karenina from Tolstoy. I think that he wrote it almost despite himself. A fallen woman, right? He wanted to be critical of her, and yet he animated her with a story that is anything but. It's truly heroic, in this way. I have I mentioned Abraham Verghese. You cannot go wrong. All his books. The first one is My Home Country, about men that were coming to New York with AIDS, with HIV, and nobody knew what to do with them because it was not a disease yet, and they didn't want to go to their local towns because of being embarrassed or other things, but they just clustered in New York. The second book, Tennis Partners on Addiction, phenomenal, absolutely phenomenal. and true. I have actually had colleagues that struggled with this. Um, Cutting for stone is his story as somebody who came from Ethiopia and trained in one of the hospitals in New York and lost a brother. And then his essays. His essays are absolutely fantastic. Um, he wrote an essay, and I told him to help me locate it if anybody's interested, on Rothko, whom I never really admired much until I read how he saw it, from his perspective. Um, I'm a fan of what's cool. So I like London. I mentioned that we lived in Britain, and when I work with several hospitals there and stuff, and I have this, as we all have, we have sites, we have places where we like to go. Mecklenburg Square, is my favorite. Not well known. That's part of the allure. For me, I stay in what's called Good Enough Club. I'm not a member of the club. Somebody, always needs to give me an access to it. It's quiet. It's a cemetery actually in the garden, and there is a small store called School of Life, and I always go there. I admire Alain de Botton. Never met him, but he wrote several phenomenal things about how can Proust change your life, um, um, and others, and always learn from the guy. So I can
Thank you
go
for
on, but we don't have time.
those are great. We're going to wrap up with one more question. And for the interns, just know that we do keep a list of these books and recommendations on the website, so you can refer to these and others that have been offered up by some of our guests. The interns are doing interprofessional team work, and I think it would be great to end on a few reflections from you, VP Tolar, with respect to teamness and interprofessionality. There were a few other questions about the med school and med school expansion in Duluth, and I think certainly you could speak to some of that if you would like, but ending on the interprofessionality piece might also be nice.
Absolutely. So I'm just going to briefly say we opened the new medical campus in St. Cloud. The first students are being, interviewed now. They're going to be 24 of them starting next fall. Simultaneously, we have expanded the Duluth medical campus to year 3 and year 4. It is based on our commitment to rural life and really what people ask us to do. And I believe in rural life. I really think that this is a tremendous asset that we need to help build, and that's why we extended ourselves into that direction. The interprofessional, is a absolute given for me. It has been even before it was called interprofessional, because my BMT team has always had nurse, pharmacist, always the parents, so we around it always together. And I was, and probably still am the only one who actually, after rounds, gathered nurses and pharmacists and said, what do you want to talk about today? And they said, graft-versus-host disease, or how about these side effects, or what did we see on the floor? And I always genuinely, and I was very explicit about this, I learned from the nurses more than from my colleagues because they are there 24/7. I am there half an hour a day or something, and they know things I don't. And I think that they understood, that I saw no difference between being a physician or a nurse or a pharmacist or OT or PT or anything like this. In the operating room, the same thing. My OR always started by going around. Everybody knew everyone, and it was very clear that everybody has the same value and valence, in this. And then it's a interprofessional in a way that um, AVP Porta, has a great legacy in this already, how we have disciplined it into not an example here and there, but really made it into a system that is a permissive environment for amplification of talents of people who come from different parts of the healthcare ecosystem. So the team has always been the unit of function. I know of no physicians, and for that matter, no scientists that accomplished much on their own. This is always the unit is the team, and Howden knows well that in leadership it's the same thing. It's a team effort that I ask people to co-create with me as one of the players. So I have been a fan of interprofessional before it became named interprofessional, and I think this is the only genuine successful way of advance.
Thank you, VP Tolar. Thank you for the time this evening. It's been a pleasure. I know some of you need to go study, but this was a gift of all of our time. Thank you.
Thank you very much, everyone, for spending this time with each other and with me. And if you have any questions or have any comments on this, I would very much like to get an email from you. And Howden knows that I respond to every email. Okay.
Yes, we'll be asking you to give us a little bit of feedback, and just know that VP Tolar is incredibly accessible, as should I be.
Okay, thank you, everyone.
Thank you for listening. Let us know what you gained from this conversation by writing a quick review. Please share this podcast with others, subscribe for future conversations, and check out our other episodes. Explore health sciences at the University of Minnesota at health.umn.edu.